Okay, great.
And,
Your slides.
hang tight.
Yeah.
People start coming in.
Okay, great. Can I see how the next one?
Sure.
10 to 12 minutes from
That's just the.
Correct.
Okay.
Okay.
Brian, kept your time.
Each presenter has 15 minutes for presenting and questions. So if you run a few minutes over, I'll let you go forward, but you're running into your. I mean, I think.
Oh, yeah.
2021 is in
2022.
Literally.
That's a good point.
Yeah, so too.
But,
Oh, like you are. I'm class. Oh, you do the year you started. Yeah, right. I know. That's why I keep messing it up. Like it's this year and finish.
You're not finishing in 22, you're finishing in
23.
Yeah, we still have it for like 6 months, 7 months.
Yeah.
Only that. It's gonna play by.
All right. If you need anything, I'll be in the back for the opening. And you're all set. You've been through this yesterday, so.
Yeah.
Okay, cool.
Yep, done this before.
Yep.
Technology is surprising. This morning I was supposed to be finishing this and sending it, but instead I was like trying to order for one of our international colleagues, and it was like it kept rejecting. I think people kept rejecting it because it wasn't me. I don't know. But if we went through like 4 Ubers, people would finally like accepted the right. I don't know what's wrong.
Oh, you want to? The title, I love it.
It's going to be a friendly audience. Like, it'll be a friendly audience. I feel like it'll mostly be embarrassing.
Making sure my phone is like, it's gonna be a small.
Previously, when we feathered.
It's good to have a sample.
Something the album's gonna that like music too, but.
well, I didn't win as much as the
So that you see what everywhere.
Yeah.
Roll good, you know. Straight. Not in this crowd. I mean, it's written there.
Is that good?
Like your Sherlock Holmes with my
You
didn't bring your You've never worn it?
No.
Even when you've gone, like, I have gone to international.
Well, international or not.
Right. I mean, they're not like flattering.
I mean, like, what are you doing?
Yeah, they're probably have to. But yeah, so I think it's really like
I went to share. Hello, everyone. I'm going to kick us off and get started. You are in the room Windflower for this verbal presentation session on hand hygiene. So welcome, everyone. This session will run an hour until 4:30. And then after this, there is the poster reception in the lobby from 4:30 to 5:30. So first up, we have Denise Vega Ocasio from CDC, who will be presenting on her work of hand hygiene in healthcare settings. Good afternoon, everyone. Thank you so much for coming here today. I really appreciate it. My name is Denise Ocasio, and I'm from CDC. And today I'm going to briefly describe to you a baseline data collection study that we conducted titled Characteristic of Hand Hygiene in Healthcare Settings in Central America and East Africa from 2020 to 2021. So proper hand hygiene is one of the most important infection control interventions proved to decrease the risk of healthcare-associated infections in medical care settings globally. Healthcare-associated infections account for increased morbidity and mortality worldwide, while hundreds of millions of people are affected by healthcare-associated infections each year. Resource-limited settings are disproportionately affected. Recent studies have estimated that about 16% of patients in resource-limited settings develop one or more infection during a healthcare facility stay compared to 7% in high-income settings. And 10% of hospitalized patients will acquire a healthcare-associated infection in resource-limited settings. Healthcare facilities in resource-limited settings face inequities related to essential wash services and hand hygiene adherence, with adherence level reported to be as low as 9%. A recent global assessment of wash in healthcare facilities in 78 resource-limited countries determined that 50% of such facilities lack access to an improved water source, and 39% have inadequate hand washing facilities. Previous studies have shown that hand hygiene adherence in healthcare workers is generally low, and that any increase in adherence is difficult to sustain. Therefore, we obtained baseline data to evaluate the factors associated with hand hygiene practices and adherence in healthcare facilities across 5 countries as part of the COVID-19 response. This baseline study was conducted in selected healthcare facilities of 5 countries, including Guatemala, Belize, Dominican Republic, Uganda, and Kenya as part of the COVID-19 response. Before describing our research methods, let's share some important definitions. We define hand hygiene adherence as the process of cleaning your hands using either soap or water and an antiseptic alcohol-based hand rub or ABHR. We define invasive procedures as the process where access to the body is gained via puncture or incision of the skin, insertion of foreign material into the body, including mucous membrane or vaccines. We developed the following categories for healthcare level definition based on country similitudes. We define primary level facilities as those healthcare facilities providing community-based preventive services. Secondary level facilities are those healthcare facilities that provide amplified outpatient services. And hospital level facilities are those healthcare facilities that provide specialized services and training. How was the data collected? Well, enumerators randomly selected 4 to 8 healthcare staff working on the day of the survey was conducted. To limit observance effect, we explained to the selected healthcare workers that we would like to observe healthcare practices on patient-provider interactions, but we did not specify that we will be observing hand hygiene practices. First, the enumerator assessed hand hygiene materials that were present at the location where the patient contact and hand hygiene observations took place. This included soap and water, ABHR, and gloves. Then during routine patient care activities, enumerator recorder potential hand washing opportunities or procedures using soap and water or ABHR. Hand hygiene procedures were observed before and after patient contact, and whether or not the patient contact was invasive or not invasive. Each instance of hand hygiene as well as each missed opportunities was recorded. We conducted descriptive statistics to understand the prevalence of hand hygiene adherence, and we then conducted multivariable logistic regression to assess association between hand hygiene adherence and various factors. Our results: a total of 104 healthcare facilities participated in this study, 52 in Uganda, 20 in Kenya, 19 in Guatemala, 11 in Belize, and 2 in the Dominican Republic. Secondary healthcare facilities, seen in yellow, were more predominant in Uganda and Kenya. Hospitals, shown in purple, were predominant in Belize. Primary healthcare facilities, shown in green, were more predominant in Guatemala. And only hospitals were visited in the Dominican Republic. A total of 549 healthcare workers were observed, 146 in Uganda, 57 in Kenya, 67 in Guatemala, 142 in Belize, and 137 in the Dominican Republic. Nurses, seen in yellow, were more predominant than other healthcare worker types in all countries. A total of 4,002 hand hygiene observations were conducted, 1,066 in Uganda, 314 in Kenya, 488 in Guatemala, 742 in Belize, and 1,392 in the Dominican Republic. Half of the observations were recorded before patient contact, and the other half after patient contact. In terms of hand hygiene resources available when the hand hygiene observations took place, gloves were available during 60% of the observations, ABHR during 80%, and soap and water at 46% of the observations. Overall, our results indicated that hand hygiene adherence was 29%. Among hand hygiene practices observed, the rate of using gloves was observed 28% of the time, the rate of using ABHR was observed 22% of the time, and the rate of using soap and water was observed 10% of the time. It is important to know that while gloves are a protective barrier, they are not considered adherent and hand hygiene practices. Among procedure interactions observed, the rate of hand hygiene adherence was 34% for invasive procedures, compared to 27% in non-invasive procedures. Among the patient interactions observed, the rate of adherence was 20% before patient contact, compared to 39% after patient contact. Among the healthcare level facilities observed, adherence was observed 32% of the time in primary healthcare facility, 33% of the time in secondary healthcare facilities, and 27% of the time in hospitals. Among the healthcare workers observed, adherence was observed 34% of the time of physician, 27% of the nurses, and 26% of lab technicians. The rate of hand hygiene adherence was 28% for Uganda, 22% for Kenya, 39% for Guatemala, 52% for Belize, and 16% for the Dominican Republic. We calculated the odds of hand hygiene adherence by associated practices and characteristics, and we found that healthcare levels was not associated with hand hygiene adherence. Nurses and other healthcare workers were less likely to practice hand hygiene adherence compared to doctors. Hand hygiene adherence was more likely to occur after patient contact compared to before patient contact. Hand hygiene adherence was more likely to occur during invasive procedures compared to non-invasive procedures. Hand hygiene adherence was more likely to occur in Uganda, Guatemala, and Belize compared to the Dominican Republic.
and hand hygiene adherence was more likely to occur when only ABHR was present compared to when only soap and water is present. Our study has several limitations because the data was collected in only selected healthcare facilities. The data is not representative within a country. Because the data collection progress was not simultaneous among countries, and hand hygiene observation tools vary slightly by country, and it was adapted based on needs. We were not able to collect information on the presence of hand hygiene materials available in all countries. Observations and materials available vary by location within healthcare facilities, and observations were conducted at different times during the COVID-19 pandemic response. In summary, we found that the overall prevalence of hand hygiene adherence was 29% among those observed. The prevalence of hand hygiene adherence was higher in Belize. Nurses were less likely to practice hand hygiene adherence compared to doctors. Hand hygiene adherence was more likely to occur after patient contact, during invasive procedures, and when ABHR was present. In conclusion, ABHR availability was associated with higher hand hygiene adherence, suggesting a need for sustained production and access to ABHR. Results from this evaluation may facilitate prioritization of interventions to address gaps in access to hand hygiene resources and ways to improve hand hygiene adherence. We want to acknowledge and thank our partners involved in this study, and of course, the funding agency that allowed us to be here. Thank you so much, and open for questions. Sure.
Hey, great presentation, thank you. I'm curious, so the 5 key moments are a big part of looking at hand hygiene among healthcare workers, and that includes interaction with the environment around the patient. I'm curious if you guys thought about that as part of this, rather than just simply before and after patient contact. And the other question is about recontamination. There's a whole body of work by London School about the issue of recontamination after patient contact. And I'm wondering if that was something you looked at as we thought about like before and after patient contact, if there was like another piece to the recontamination.
When you said contamination, do you mean like if they touch something different?
Yeah, like they would then like have to rewash their hands again.
Yeah, so the way that it was designed, the study, if they would like touch something else after patient contact, then that will be defined as the ending of the healthcare, the observation of that specific patient. And then if they come back to that patient, it counted as restart as a new patient. Mm-hmm. And your first question, I'm so sorry.
No, sorry, the 5 key moments include environmental like interactions with the environment and touching that and having to wash your hands. Was that something you included as part of the observations?
What do you mean by the touching like other objects around the room?
Yeah, if they touch the bed, then they're supposed to wash their hands before they touch the patient again.
Yes. So, and that's what I feel like if they finish with a patient and they went to the next patient, then that counted as a before patient contact and they observed whether they wash their hands or not. And then also if they were with the same patient, then what I just mentioned, that if they went and touched something else, that will be considered the end of patient contact. Thank you.
I'm curious, so the adherence that you observed in Belize was way higher than other places. Do you have any thoughts on why that might be?
The adherence in Belize? Yeah, one of our hypotheses is that when we started collecting this data, most of the countries were already receiving materials, and for example, like ABHR from Ministry of Health or also NGOs. And at that point, Belize was already receiving like a pretty high percentage of ABHR. So we hypothesized that that might have influenced why they have a higher adherence rate compared to other countries.
Thank you, great presentation. I'm curious for the bucket of nurses, and I know you had different levels of healthcare settings. Was that specifically defined as like registered and licensed nurses, or did that also include community health workers or aides or other non-lab, non-physician healthcare people that did patient care?
Yeah, so nurses were classified as like very broad in general, and then we created another variable called others, and that one take into account midwives, for example, midwives and other healthcare staff that has interaction with the patients. Mm-hmm.
If that's it for questions, we can move on to the other session.
Thank you.
As always, our presenters will be around for the duration of the session. If you think of questions later, you'd like to approach them after, feel free to do so. Next up, we have Victoria Trini's with CDC.
Hi, good afternoon, everyone. Victoria Trini, a health scientist with the U.S. Centers for Disease Control and Prevention. And today I will be presenting a trial that we conducted looking at the role of hand hygiene technology options on hand hygiene practice. So in early 2021, the CDC, along with Washington State University and the Safe Water and AIDS Project, began implementing community hand hygiene projects for COVID-19 mitigation in 2 sub-counties in Kisumu County, Western Kenya. 34 sites were selected across these counties based on situation assessments that were conducted with the county government, which identified places with high levels of population mixing that would need COVID mitigation measures. And these sites included public service offices such as chiefs camps and police stations, markets, community organizations, agricultural processing points, and transportation booking offices. The hand hygiene interventions that were deployed included providing hand washing stations, soap, alcohol-based hand rub or ABHR, and hand hygiene promotion materials. And as a part of this intervention, we wanted to explore how best to maximize hand hygiene practice in these settings. So to help answer that question, we implemented a trial to investigate whether access to multiple hand hygiene technologies, so that is hand washing plus ABHR, improves hand hygiene practice in these community locations compared to access to hand washing with soap only. So based on sample size requirements, we selected 18 of the 34 locations for inclusion in the trial, and locations were excluded if they were deemed not to be suitable for the intervention, such as if there was no water point accessible. Pairs of locations were matched across the 2 sub-districts to ensure that there was parity between the study arms. And they were matched by location type and the number of daily visitors. And this matching, again, was just for parity. It wasn't included in the analysis models. Within each pair, sites were randomly allocated to receive either a hand washing station only, and that's our May 9 sites, or to receive a hand washing station plus ABHR. R&B sites, and they were told to place these hand washing stations by the entrance. And you can see an example of the hand washing station here. There was a detachable metal arm where to hold sanitizer that was either installed or not, depending on which arm that the site was in. R&B sites were provided with ABHR throughout the trial, and all sites were provided with soap throughout the trial to, again, enable good conditions for observations. Enumerators visited these sites once every 2 weeks. At the start of each visit, they assessed whether there were hand hygiene promotion materials available either at the station itself or somewhere at the entrance. And they also assessed what hand hygiene materials were available. And again, because this was designed as an efficacy trial, we wanted to maximize the ability to conduct observations. And so if there was no water, if there was no ABHR, or if there was no soap, the enumerators would ask the location to provide those things. And if the materials were not provided, we did not conduct observations. And then when appropriate materials were present, the enumerator stood in an unobtrusive place and observed one person at a time as they walked into the location and passed the hand hygiene station and noted whether or not they performed hand hygiene. If they did perform hand hygiene, the enumerators recorded whether they used water only, water and soap, and or used ABHR. Enumerators also recorded the sex and the age category of the person, which they visually assessed as either child, adolescent, or adult. Observations ended once 10 visitors had been observed or until when 2 hours had passed. And if a site had really low frequentation of visitors, the enumerators would come back for an additional visit at another time. After 6 rounds of observation, there was a crossover. ABHR was provided to the Arm A sites and was removed from the Arm B sites. And then we continued observations for another 6 rounds for a total of 12 rounds. And hand hygiene practice between the study arms was assessed in SAS using logistic regression, controlling for sex, and observation round with generalized estimating equations to account for clustering within locations. So apologies in advance, this is going to be a messy slide, but we conducted 231 location visits. Hand washing stations were present at all of the visits. 16 of the hand washing stations did not have water. When asked to refill, only 1 of them was not refilled, and so that site was excluded, or there were no observations. Of the 230 hand washing stations with water, 212 had soap, 18 didn't, and of those, 1 soap was not able to be refilled. And then of the 229 hand washing stations with water and soap, about half of them had ABHR, which was as expected, so that was good. 9 of those, they had ABHR containers. 9 of those didn't have ABHR in them, and 3 of them were not able to be filled and were excluded. So in all, enumerators conducted 226 location visits where conditions were suitable for observation. And across these visits, enumerators observed 2,207 people entering the locations. 37% of people observed were female, 97% were adults, and ABHR was present at 49% of the observations. Overall, we observed that 8.3% of visitors performed hand hygiene upon entry to the community locations. And just to note, when we talk about hand hygiene here, we're talking about washing hands with water and soap or using ABHR. We did not consider washing hands with water only to be proper hand hygiene. Visitors performed hand hygiene more often when ABHR was present compared to when only a hand washing station was present. So when ABHR was present, 10.4% of people performed hand hygiene. When it was only hand washing, 6.3%. And this difference was significant in our models. So if we zoom in really far down and look at the proportion of type of hand hygiene that was performed, we see that really the proportion of people who wash their hands with soap, which is in blue, is similar between the 2 arms at 6 to 7%. But there was an additional 3% of people who used ABHR either alone or in addition to water or to water and soap. And so this chart zooms in on just the hand hygiene practice across our 12 arms. And the hand washing station only arm is on the left, and the ABHR arm is on the right. So we see that there's some variability in practice across the rounds, but there's consistency in that the ABHR rounds is pretty much always, there's always a higher proportion of people practicing hand hygiene. We also see that there's a bit of a decline over time in the proportion of people practicing hand hygiene, which we think is due to the fact that people's concern about COVID was declining, and also there was the removal of some COVID-19 mitigation measures, such as when the mask mandate was dropped. And also you'll note that the highest proportion of hand hygiene was when the interventions were first installed, showing probably some reactivity due to the novelty of the interventions. So in conclusion, we observed that people performed hand hygiene upon entering public places more often when they had the option of both hand washing and ABHR compared to when only hand washing stations were present. We also observed that even when ABHR is present, the majority of people entering these locations were still using hand washing with soap, which really indicates that that is the preferred practice in this population, And even though ABHR is easy and convenient, we need to make sure that hand washing stations are still available to support that preference. And then finally, we noted that even when the options were there, hand hygiene practice was still really low, a lot lower than we were expecting to see. And we think this may reflect the novelty of performing hand hygiene at entrances in this population. And so we decided to do these observations at entrances because the recommendation that hand hygiene should be performed when entering public places was something that came out during the COVID-19 pandemic as one of the key mitigation measures. But prior to COVID-19, that had not been traditionally considered a key moment for hand hygiene. So this was a novel moment, and it could have been that because COVID-19 risk perception was down, people were not continuing that practice, or maybe it had never been like truly internalized as a consistent practice. So, oh, this is old slide. So a few limitations in addition to the observation point and the declining COVID perception. There were challenges with maintaining soap. There were a number of instances where soap wasn't available, and our partners reported it was because soap was getting stolen. We were using bar soap, and so they wanted to transition to liquid soap and finding other ways to make those supplies more consistently available. We also didn't look at the efficacy of practice, like whether people performed hand washing with soap for the required 20 seconds. And we weren't able to get good disaggregated age data because we relied on visual assessments of people. So it's hard to categorize. Next steps for this analysis include evaluating the effect of communications materials and the effect of whether or not there was a site that habitually didn't have soap available and like may have created a expectation that materials weren't going to be available. And then next steps for the project are exploring additional approaches for improving hand hygiene practice. So I wanted to thank our partners and funders and can now take any questions.
So the hand washing stations, hand hygiene stations were at the entrance. Was there any indication of requesting people to actually use them, or was there, I mean, you mentioned communication at the end there.
Yeah, so we actually did record whether or not there was an attendant present, because that was something that had been happening in the past, but there were never any observations when an attendant was present. And there was no I don't know if people, once they got inside, were getting instructions. There was like general communications about performing hand hygiene at entry during COVID, but not specifically for those sites, unless they had. No, they just had things like, I don't know, the picture, there was like, a hand hygiene steps next to the station, but nothing that was like, wash your hands here. Yeah. Yeah.
Do you have any data on the placement of these? I mean, beyond just being at the event, the big differences have to physically move around a training station.
We don't have, we didn't collect consistent data on that from my site visit. So one of the challenges with these was that the material of the plastic was degraded if it was in the sun. And so they had to place them, or they tried to place them in the shade to like increase the durability of the plastic. And so sometimes that was like, in the picture that I showed, it was against a wall, and there was like a doorway that you walked in, and the hand washing station was to your left when you walked in. So it wasn't right in your line of sight. In other places, it was like you walked in and there was a hand washing station like right there. So there was some variability, but we don't have data on that. Yeah.
You hired market?
So this was markets. Most of them were public service offices. So like chiefs camps and like revenue offices and NGOs or CBOs.
I'm wondering about Robert's question, if there's any difference depending on the institution. Like because I was talking to David about this earlier, like walking into schools we have. So if like you think this if it's a school or if it's a certain type of institution or entrance, that might be different than the
That's something we because there were only 2 markets and 2 CDOs, and the other ones were these like public service offices. So we don't have really enough data to really, like, there's not enough variability in the data to disaggregate. It would be great if to be able to apply this to other settings, not entrances, you know, other like near eating areas and like a wider variety, I think, to be able to tease that out, but we can't say that. Yeah. Lindsay.
You mentioned at the very end there about how like you switched out from bar to liquid. Was that, or they were talking about doing that? Is that something that happened at different sites? Like, how did that work?
We do have data on the type of soap that was available. It was almost all bar soap. Some locations, we did not provide liquid soap as a program project. We were just providing bar soap. Some locations provided their own liquid soap because of preferences. I think in addition to the problem with the theft, there was also from our qualitative work that we did, there was a preference for liquid soap because people didn't want to use bar soap that other people's hands had touched. And so some sites put that out themselves. I don't have that data with me, but it was the overall majority was bar soap. And I think we're wrapped up, but there might be some more questions at the end.
Yeah, if you could just hold your questions for now. I'm sure Victoria, I'm volunteering you to stick around and answer those questions after the session if you would like to do that. But thank you, Victoria. What's your presentation? This one?
Yeah, the copy the first one.
The first one. Okay, great. Great. Our final presenter of the day is Dr. Evans Asanane, who will be presenting his qualitative study on communal hand washing.
Thank you. Quite different from the other 2 presenters. Yeah. So, growing up in northern Ghana, I've experienced times where people practice different forms of improper hand washing practice, where in some cases I also took part in, like washing with ash or just dipping your hand in. These practices have persisted many decades, despite the different forms of health education and the interventions. The question is why? Why have these improper hand washing practices persisted? Even there was this the episodes of the Ebola, now with the pandemic of the COVID, these practices still persist. So today I present the findings of a culturally ingrained form of improper hand washing practice called the communal hand washing practice, where a group of people, 2 or more, wash hands in one shared bowl of water without changing the water, and usually without using soap, just like the photos show. And this is before eating. Yeah. So there's evidence to suggest the risk of this practice in many settings. So in Kenya, in 2015, at the peak of the cholera epidemic, this case control study found out that there was also 6.5 of households that practiced communal hand washing versus households that did not in contracting cholera. Similarly, in Zimbabwe, they also found out that there was a risk of contracting diarrhea in children less than 5 years that were practicing communal hand washing versus those that were not practicing communal hand washing. Then to look at these microbial studies in Ghana also, they found out that they conducted a microbial study where they took the sample of the water and hand swabs after communal hand washing. And it was found out that from the hand swabs, there were increased pathogens after practicing communal hand washing. And this was recently done in Mali, where my team looked at an intervention where they practice communal hand washing with soap, and the control where they just practice communal hand washing the traditional way. And in the control, there was increase in E. coli positivity. So given this, we wanted to find out, the aim of our study was, this qualitative study was to find out what is the perception and motivation for this practice. And we conducted this study in rural and urban Mali in West Africa, located here in areas of Bamako, Sikoso, and Kulukuru. So the findings I'm presenting are from 2 separate related qualitative studies The second one was built on the back of the first one. So I'll call that study one. So study one was done in 7 communities, both urban and rural communities. And we conducted focus group discussion separately with mothers, fathers, grandmothers, and elders in the community. Then there were 7 to 8 per each group. For study 2, it was conducted in a similar setting, but in 5 communities. And this one, there were interviews that were done with 30 household heads and 30 mothers. In both studies, the participants were conveniently sampled. Now, we analyzed the data for both the focus group and interviews were conducted in Bambara, translated into French for our use, and we used thematic analysis, adopting an inductive approach. What did we find? So we found 3 key themes that came out. So firstly, the commonality of the practice, then motivations for the use of communal hand washing, and also the description and other adaptations they were making. And for the motivations, there were these sub-themes that came under it: the unity, the tradition, negative perceptions of soap, scarcity of water or hand washing device, and perceived no consequences. And for the last sub-theme, the description of the practice, we had the order of the practice and the current adaptations others were making. Now I'll go in depth to look at them. So for the first theme, the commonality of the practice, it was reported that this practice, communal hand washing, was done by almost everyone, every household, by every member of the household. And these were usually with before eating. And it was done together with communal eating, where after washing their hands in one bowl, they eat together using their hands in one bowl. So communal hand washing, then communal eating together. Then outside households, in major gatherings, it was also practiced. Then the second theme, the motivation of the practice. So the first theme was the family unity and solidarity. So this practice was seen as a way to preserve the unity of the family, to bond the family together, solidarity within the family. And the code here says that it strengthens family ties. It's meant to strengthen the bond because I touch your foot, you touch mine. So they were cognizant of the fact that washing in this communal bowl, it comes out and all this. But with that, they still practice it because of the benefit they were getting from it. Then also with communal hand washing, so it's also seen as a sign of unity for outsiders that are around seeing the family practicing it. For others, it was just tradition. The idea to keep up the tradition because this was from their forefathers and passed on to them. Then for the others found out that for others, the practice of it wasn't for the tradition, it wasn't for the bonding of the family, but just absence of water or scarcity of water or the hand washing device. And in Mali, they have this common hand washing device, which is like a plastic kettle and a bowl with a perforated lid where they can wash individually. So without this, the others just practice the communal hand washing. Then others also just had negative perception of the use of soap, the fear of ingesting the soap during eating. Others also reported that soap was a foreign item, a foreign material. Hence, those that were using soap washes everything away, including their wealth. So the more you keep washing, the more you don't have anything left in your pocket again, as we can see from the team there. Then for the last team and motivation was the no consequences. Others asked, why use soap? Why change? This is a practice we have done over the years. Nothing has happened. They haven't had any adverse consequences from it. So why change? Then for the last team, the description of the practice and adaptations. So for the first one, the order and timing of it. So communal hand washing was seen as a sign of respect, where they practice hand washing by age. The elders being the first to wash and children being the last to wash. Then this is quite interesting. They said in the past, after washing, the water contained in the bowl was often given to a child to drink because it's meant to strengthen the child from illness and also from spells that have been cast on the child. However, a lot said this is no longer the practice, they just discard the water. Others made very slight changes to the practice of communal hand washing, where they just they either wash individually and now practice communal hand washing, or vice versa. So in that case, they were cognizant of the fact that they wanted to still benefit from the tradition of communal hand washing, the bonding within the family, but they also wanted to improve hand washing. So as you can see from this code here, they're saying while respecting tradition, they first wash in the communal, with individually using the plastic kettle I showed, then now they practice communal hand washing. So to conclude, we found out that this was a common practice in Mali, and this, given the order of practice, it poses risk, especially to the vulnerable, the children being the last to wash. Then also we found out that people were very reluctant to change for the need to keep up their tradition, for the need to keep up the bonding within the family. And others, as we saw in the last slide, made slight adaptations to the practice. So designing culturally sensitive interventions using findings like this will be able to improve hand washing within these communities. Thank you very much. Yeah.
I'm curious if the use of the kettle and the pour over, did it come out whether people saw that as like maintaining the tradition? Like, was that still seen as a bonding act, or was that seen as something else?
Yeah, that was seen as something else. As we can see from the last quote, they want to still use that, but afterwards, they still have to do communal hand washing. So you see, so they will still use the kettle where they can wash individually, but afterwards they have to still dip their hands in this common bowl so that they can derive the benefits from it. Are you moderating? Should I take it? Okay. Joe?
Hi.
Yes.
Question on the theme around motivation looking for this. Did you quantify the number of times people described the different motivations that you listed? What was the most common reason that people gave for wanting this?
Yeah, so the most common was the very first one. So I tried putting them. So there were two that went hand in hand: the tradition and the family, the bonding. So this was mainly one of the things that they didn't want to get away from it, because they wanted to still keep up that unity within the family. They don't want any betrayal within the family. And this was mostly with polygamous homes where the man has more than one wife. So when they are practicing this, they stay united within the family rather than having divisions within. Yeah.
I'm just curious if in collecting this data focused around communal hand washing, if you also collected data amongst these households around barriers to adoption of other alternatives. I don't know if there was any information that you gathered related to if some of those households had availability of hand washing materials like soap and the kettle method, as you were kind of cross-referencing their preferences and motivation.
Yeah, in a follow-up study, we did try to look at that, where we asked them, do you have a plastic kettle and bowl? And whether you use it. And in some cases, they have it, but it's reserved for visitors. It's reserved for an important person coming in. Yeah, so that was what we looked at, but I don't have that data in. Yeah.
Two kind of related questions, I guess.
Questions.
I guess the soap finding that you had about kind of the desire to not use soap in this, was that specific to this act, or was it specific, or did it also extend to other moments to wash hands, like after using the toilet or other areas? Was it sort of a general, was it specific sort of to communal hand washing specifically? And then when did you collect this study? Just to clarify, I'm curious if COVID influences the whole test.
Yeah, we didn't. So this data was collected after, I think during when COVID was about dying down. And to answer the first one, where the soap was just seen as a foreign material. So regardless of using it as in the communal bowl or even using it otherwise, they didn't want the use of soap when washing hands, because this was like washing once, everything away, including your wealth. There was another part that, due to time, I didn't get to that, where they reported that, due to the COVID, when the COVID was at its peak, we adapted to either washing individually or with soap. But as the COVID died down, we went back to the tradition again, where they have to do that. So it was like the fear of the COVID came, and afterwards it went down again.
So as a public health person, I wash my hands all the time, which may explain perhaps my lack of health. You talked about trying to bring in a culturally appropriate way to get people to wash their hands. Did you get any sense from this or follow-up studies what that might be or how you might proceed? Yeah,
so that's our next step from this. So we're currently looking at funding to develop a culturally sensitive intervention. But we did try a feasibility study in Mali where we want them to keep up their tradition, washing the communal bowl, but add soap. But we don't know whether the cross of pathogens, how that will be like. So we are still analyzing that data. Where they washed with soap, then we took hand swabs of the last person that washed with the soap and rinsed together in one bowl. So we're looking at a way that will still let them do it, the togetherness, to do it to still maintain that bonding, that unity within the family without, because that would let them, motivate them to practice it. Yeah.
Very quick one. How many people would be in a family that would be sharing one bowl?
Mainly from 6 to 10 people within a household. So we have the bigger households than that, but some households minimum will be 6, where the child waits patiently at one side, and it starts from the head of the household, washing down to the child to now dip their hands and wash. And even with friends sitting, as we can see from the first picture, that was just a group of friends about to eat, and they brought the bowl. They will just, one will wash, pass it to the other, they will wash before they start to eat. Last one.
Sorry, last question. Would they refer to this as hand washing, or is it more just like a bonding thing you do before a meal? Like, is it seen as something to prevent you from taking in pathogens when you eat?
I don't think that's how. Some did see it that way, and others that saw it that way, maybe from education. Others are the very few that were trying to make slight adaptations, but they still wanted to keep it. But I think they just saw it as, well, we have to wash our hands before we eat. This was a practice that was passed from our forefathers to us. People that wash their hands together stay united, stay bonded, than those that do not. So those were key to it. Yeah. All right. Maybe afterwards, yeah, I think. Yeah. Thank you very much. Yeah. Yeah.
Great, we're running a few minutes ahead of schedule today, so thank you again to all of our great presenters. We have just about 10 minutes until the poster reception formally kicks off. You're welcome to wander out early or stick around and chat with our presenters after the session, but thank you for coming.
Nice job.